Imagine lying in bed, you're like utterly exhausted, eyes heavy,
Yeah.
but instead of drifting off, your brain is suddenly treating your mattress like it's some sort of threat level midnight situation.
Oh, yeah.
For up to 60% of women in their 40s and 50s, I mean, this isn't some rare nightmare scenario. It is literally just a Tuesday.
Yeah, it is the absolute definition of a biological curveball. We
Wow.
see women who have been, champion sleepers their entire adult lives,
Right.
people who could sleep on airplanes or through thunderstorms, and suddenly they find themselves wide awake, staring at the ceiling at 3 a.m., just completely baffled.
Okay, let's unpack this, because that sudden loss of ability is incredibly validating to just acknowledge right off the bat.
Mm.
The mission for today's deep dive is to tackle this massive, often unspoken challenge of menopausal insomnia.
Absolutely.
And our goal is to equip you with highly effective, science-backed lifestyle adjustments so you can actually reclaim those restful nights.
And we aren't just guessing here, right? We are looking at a huge mountain of data.
We really are. We've got clinical guidelines from the National Institute for Health and Care Excellence, or NICE, the British Menopause Society, the massive SWAN study tracking women's health over 15 years, and even, practical sleep hygiene guides and real patient experiences.
Exactly. And if you were listening to this and dreading nighttime, the absolute first takeaway from all this literature is that this is not a personal failure.
Yeah, that's so important to hear.
You haven't lost your touch. You are navigating a profound physiological shift. It simply requires a completely new toolkit, because the old rules of just winding down, they don't apply when the underlying chemistry has actually changed.
So before we can fix the sleep problem, we need to understand the mechanics of the sabotage. We know hormones are dropping, but I've always thought of estrogen and progesterone purely as reproductive hormones.
Sure, yeah, that makes sense.
How are they acting as literal sleep aids in the brain?
Well, that is a really common misconception, but their reach goes far beyond reproduction. Estrogen, for example, is a master regulator in the brain. It supports the production of serotonin, which you might know as a mood stabilizer, but it is also a crucial precursor to melatonin, the sleep hormone.
Oh, wow.
And estrogen also naturally helps lower your core body temperature at night.
Which is a requirement for deep sleep, right?
Exactly. It's a hard physiological requirement for entering deep sleep.
So when estrogen drops, the melatonin assembly line basically slows down and the body struggles to cool itself off. What about progesterone?
So progesterone acts as a central nervous system depressant, in a good way, obviously. It binds to GABA receptors in the brain.
And GABA is the calming one.
Right. GABA is your primary inhibitory neurotransmitter. It's the chemical that basically tells your neurons to calm down, stop firing so fast, and just relax.
Got it.
Progesterone activates those calming pathways, promoting deep, slow-wave sleep. It also acts as a respiratory stimulant, which keeps your airway open. So when those two hormones begin fluctuating wildly and eventually drop, the brain's internal environment is thrown into total chaos.
The sources kept bringing up the hypothalamus in relation to this chaos. That's the part of the brain that acts as the body's internal thermostat, right?
Ah.
Regulating temperature.
Yes, exactly.
How does the hormone drop actually break the thermostat?
Well, it doesn't break it, but it drastically narrows what we call the thermoneutral zone.
Thermoneutral zone.
Yeah, think of the thermoneutral zone as the acceptable temperature range where your brain feels safe. With normal estrogen levels, that zone is fairly wide. You can get a little warm or a little cool, and the body just makes minor adjustments.
Like kicking off a blanket or something.
Right. But without estrogen, that zone shrinks to a razor-thin margin.
So it's like having a home thermostat that is suddenly incredibly sensitive to just a 1-degree shift.
Exactly the mechanism. Because that acceptable zone is so narrow now, a tiny normal shift in your room temperature, or even just rolling over under a blanket, triggers a massive, disproportionate reaction. The hypothalamus registers that tiny increase as a life-threatening overheating event. It hits the panic button, triggering a massive release of adrenaline to force your blood vessels to dilate and sweat glands to open, rapidly cooling you down.
And that adrenaline dump is the hot flash and the night sweat.
You got it.
But wait, I have to push back slightly on the sequence of events here. Because in reading the patient accounts, a lot of women report waking up first, and then the hot flash washes over them, like a minute later.
Right.
Or they wake up with a racing heart but no sweat at all. If the heat triggers the wake-up, why the delay? Is the brain actually forgetting how to sleep?
What's fascinating here is that the clinical data reveals it's a two-way street. Researchers have found that the actual neurological mechanism of waking up from a lighter stage of sleep can trigger the hot flash.
Oh, wow. So just the act of waking up causes it?
Yes, because progesterone has dropped, your sleep architecture is missing that deep, slow wave anchor. You are spending way more time in lighter sleep stages. Your brain is hovering near wakefulness, easily disturbed. When you transition to waking, it can trigger that hypersensitive hypothalamus to initiate a hot flash.
That structural fragility makes the SWAN study data make total sense. I mean, they followed women for 15 years and saw this sleep fragmentation start early and just persist.
It really does.
If the brain's thermostat is this fragile and the sleep architecture is missing its chemical anchors, the immediate next step has to be managing the external environment. If the internal system is overreacting, we need to eliminate external triggers.
Absolutely. We have to engineer the environment to compensate for the lost biological buffers. It essentially becomes an exercise in microclimate management.
Which brings us to the quick wins. I was reading through the real-world patient experiences, and one woman completely solved her night waking by doing something that sounds almost like a joke, the Scandinavian sleep method.
Oh, yes, the separate duvets.
Yeah, here's where it gets really interesting. It turns out sharing a heat-trapping blanket with a partner who runs hot is actively sabotaging your microclimate.
It is brilliant in its simplicity, really. When that thermoneutral zone is razor thin, your partner's body heat radiating under a shared heavy duvet is more than enough to push you into a hot flash.
Makes perfect sense.
Having two single duvets allows you to select a lightweight, breathable option for yourself, entirely isolating your sleep climate.
The clinical guidance also gets incredibly specific about room temperature. The ideal range is between 15.6 and 18.3 degrees Celsius, which is honestly quite cold.
It is on the cooler side, definitely.
And then there's the clothing. Heavy fabrics hold heat and sweat against the skin, which just prolongs the physiological panic. The recommendation is loose, natural fibers like bamboo, cotton, or viscose.
Because they wick moisture and allow for rapid evaporation.
Right, and evaporation is key.
Exactly, because evaporation is what actually cools the skin and signals the hypothalamus that the crisis is over, which stops the adrenaline rush.
One patient even mentioned keeping a damp cloth and a bowl of ice by the bed for a 2 a.m. cool down.
That is a highly effective practical strategy. But engineering the body's environment goes beyond just temperature and fabrics. We have to look at daily inputs.
Okay.
If the nervous system is highly reactive, we need to look at what you are consuming that might be pouring gasoline on the fire.
Which brings us to the stereotypical evening glass of wine. I mean, a lot of people lean on alcohol to unwind, especially if they are already anxious about their inability to sleep. It feels like a sedative.
It feels like a sedative because alcohol is a central nervous system depressant initially. It mimics GABA, helping you lose consciousness.
It's a trap, right?
A massive trap. The way the body metabolizes alcohol is a biological disaster for menopausal sleep.
How so? What is it actually doing in the background?
Well, a few things. First, alcohol is a potent vasodilator. It forcibly widens your blood vessels, bringing hot blood to the surface of your skin.
Oh, so you're artificially heating yourself up.
Yes, which immediately triggers that oversensitive hypothalamus. Second, as your liver clears the alcohol from your system in the middle of the night, your brain experiences a rebound effect.
A rebound effect.
Right. Alcohol initially suppressed glutamate, which is an excitatory neurotransmitter. As the alcohol wears off, the brain gets flooded with a massive surge of glutamate, violently jerking you awake into a state of high alertness. This completely shreds your REM sleep.
Wow. So that 3 a.m. wake up where your heart is pounding and your mind is racing, that is the glutamate rebound.
It is. Cutting back on alcohol, particularly in the hours before bed, is repeatedly cited in the literature as one of the single most effective, immediate changes you can make to reduce nocturnal wake-ups.
I also noticed the sources focus heavily on the timing of exercise. I mean, moderate exercise is highly recommended, but doing vigorous exercise within 2 to 4 hours of bedtime is a massive saboteur.
Because vigorous exercise raises your core body temperature. And unlike a hot flash, which is a rapid spike and fall, your core temperature stays elevated for hours after a hard workout.
And you said earlier we need the core temperature to drop to get deep sleep.
Exactly. If you try to sleep while that core temperature is still elevated, you won't be able to enter deep sleep. Also, it's recommended to cap daytime naps at 20 to 30 minutes in the early afternoon so you don't eat into your nighttime sleep drive.
That makes perfect sense. The guidance actually suggests moving that vigorous movement to the morning, preferably outside.
Yes, morning light exposure is critical.
Because it hits the retina, shutting off residual melatonin, and sets a 14-hour biological timer that tells the pineal gland exactly when to start producing melatonin again that evening.
You are setting the sleep dominoes up early in the day so they fall perfectly at night.
Okay, so let's walk through a scenario. Someone takes all of this advice. They drop the room temperature to 16 degrees, they buy the bamboo pajamas, they do the Scandinavian separate duvets, they ditch the evening wine, and they walk in the sunshine every morning.
Okay.
And they are still lying there staring at the ceiling at 3 a.m. The body is cool, the inputs are clean, but the sleep just isn't happening. What then?
That is the pivotal moment where acute hormone-driven sleep disruption has mutated into a psychological phenomenon known as chronic learned insomnia.
Learned insomnia.
Yes, the biological triggers might be managed, but the brain has learned a new maladaptive pattern.
The sources described it as a psychological loop. Can you explain how a biological hot flash morphs into a psychological loop?
Think about classical conditioning. Over months of lying awake, sweating, feeling your heart race, and stressing about how exhausted you were going to feel the next day at work, your brain forms a new neural association.
It associates the bed with stress.
Exactly. It stops viewing your bed as a cue for relaxation and rest. Instead, it starts viewing the bed as a cue for frustration, anxiety, and wakefulness.
No.
You are essentially training your nervous system to enter a fight-or-flight state the moment your head hits the pillow.
So all the cooling sheets in the world won't fix that, because your nervous system is treating the concept of sleep itself as a threat.
Precisely. And to dismantle that threat response, medical bodies like NICE and the British Menopause Society universally recommend cognitive behavioral therapy for insomnia, or CBT.
That's CBTI.
It is the gold standard first-line treatment. Long-term, it frequently outperforms sleeping pills because it rewires the neural pathways causing the hyperarousal rather than just chemically bludgeoning the brain into unconsciousness.
I really want to dive into CBTI because it generated some very strong reactions in a Reddit thread from a menopause support group included in the sources. People need to know this isn't just a therapist telling you to think positive thoughts about sleep.
Oh, no, not at all.
It is an intense, rigorous program, and one of the core pillars is something called sleep restriction therapy.
Yes, and it is famously difficult, which is why people resist it, but the physiological mechanism behind it is incredibly powerful.
Looking at this Reddit user's account, she was dealing with severe perimenopausal insomnia. She said sleep restriction was brutal. The way it works is, if you are only actually sleeping for 4 hours a night on average, the program strictly limits your time in bed to 4 hours.
That's right.
So if she needed to wake up at 6 a.m., she was forbidden from getting into bed until 2 a.m.
Wait, so the cure for being exhausted is to deliberately sleep less at first? How does that not just make people completely miserable?
It is really hard. I completely validate that. It sounds totally counterintuitive, doesn't it?
It sounds like torture.
It does, but let me explain the science. By restricting your time in bed, you are forcefully building immense sleep pressure.
Sleep pressure.
Yes, sleep pressure is the physical accumulation of a chemical called adenosine in your brain. The longer you are awake, the more adenosine builds up, increasing your biological hunger for sleep. So it's basically like physical therapy. Yeah. If you break your leg, physical therapy hurts at first, and you might not want to do it. But deliberate, controlled stress is the only way the bone heals correctly. Sleep restriction is just physical therapy for your sleep architecture.
I am absolutely stealing that analogy. That is spot on. By forcing yourself to stay awake until 2 a.m., your adenosine levels are so high that when you finally do lie down, your brain doesn't have the energy to sustain those fragmented wake-ups. It compresses that light, broken sleep into a single, dense, consolidated block.
And then you slowly earn more time back, right?
Like
Don't stay at 4 hours forever.
Right. You track your sleep with a detailed diary. CBTI uses a metric called sleep efficiency, which is the percentage of time spent in bed actually asleep.
Okay, so how high does it need to be?
Once your sleep efficiency hits about 80%, meaning you are asleep for almost the entire time you are in bed, you are permitted to add 15 minutes to your sleep window the following week. You slowly stretch the window, forcing the brain to associate the bed entirely with sleep.
Because face-to-face CBTI is really hard to access, finding an in-person certified therapist is difficult and expensive. But the digital landscape has completely changed this.
It really has.
NICE actually officially recommends AI-driven digital therapeutics. An app like Sleepio provides a tailored 6-week program, virtual experts, and automated tracking that even syncs with smartwatches to calculate that sleep efficiency score for you.
The health economic models in the guidelines showed that prescribing digital CBTI apps actually saved the healthcare system money because it dramatically reduced the long-term reliance on sleeping pills. It makes this intense therapy actually accessible, giving the patient the exact tools they need to retrain their own brain right in their own home.
So we have addressed the biological thermostat with the environment, we've tackled the lifestyle inputs, and we've rewired the learned insomnia with CBTI.
Right.
But the sources highlight one more critical layer. There are hidden medical saboteurs that mimic menopausal insomnia, things that bamboo pajamas and physical therapy for your sleep architecture just cannot touch.
This raises an important question because we have to look at the whole patient. Menopause does not happen in a vacuum. The physiological changes of aging bring other risks to the forefront. We have to discuss obstructive sleep apnea, or OSA.
When most people picture sleep apnea, the stereotype is usually an older, overweight man who snores loud enough to shake the walls.
And that stereotype causes thousands of women to go undiagnosed. Earlier, we discussed how progesterone acts as a respiratory stimulant and helps maintain muscle tone.
Yes.
Well, when progesterone drops during menopause, the muscles in the upper airway become much more lax and collapsible during sleep. So, a woman's risk for developing sleep apnea skyrockets post-menopause.
And the presentation is completely different, right? The sources note it's not always the loud, gasping snoring.
Frequently, it's not. In menopausal women, sleep apnea often presents subtly. Think chronic morning headaches, unexplained daytime fatigue, or mood changes like depression and anxiety.
Wait, so a woman might wake up with a racing heart and a sweat, assuming it was a severe hot flash.
Exactly. When in reality, her airway collapsed, her oxygen levels dropped, and her brain dumped adrenaline to wake her up so she wouldn't suffocate. It's an apnea event masquerading as a menopausal symptom.
That is a terrifying and critical distinction. Another hidden saboteur the women's health concern fact sheet brought up is restless leg syndrome, or RLS.
Yes, RLS is a major disruptor.
This is that irresistible, maddening urge to move your legs, usually accompanied by a creepy, crawly sensation deep in the muscles at night, and it gets much worse post-menopause.
And movement only provides a few seconds of relief, making it impossible to drift off.
There was a highly actionable tip in the sources about this. If you have RLS symptoms, ask your doctor to check your ferritin levels. Why ferritin? Is low iron a hidden culprit?
It is. Ferritin is the protein that stores iron in your cells. And iron isn't just about preventing anemia. In the brain, iron is a necessary critical cofactor for producing dopamine. Dopamine levels naturally dip in the evening as part of your circadian rhythm. If your iron stores are low, your brain struggles to produce enough dopamine, and that neurological deficit is what triggers the misfiring sensor signals in your legs. Raising your iron levels can often dramatically resolve the restless legs.
Oh, wow, that is so actionable. So if you were dealing with potential sleep apnea, or low iron causing RLS, or if your hot flashes are just so violent that no amount of CBTI or cooling sheets can manage them, that is when medical intervention becomes necessary.
Absolutely. It is crucial to consult a doctor to rule out these hidden saboteurs.
And the clinical guidelines from NICE and the British Menopause Society are very clear on this. While lifestyle and CDTI are foundational, hormone replacement therapy, HRT, or non-hormonal medications can be powerful adjuncts if hot flashes are severe.
Yes. When lifestyle modifications hit their ceiling, medical treatments step in. By replacing the lost estrogen and progesterone, HRT effectively widens that thermoneutral zone back to its normal range. Or non-hormonal medications can target the brain's temperature control center directly. But the behavioral foundation will always ensure those medical treatments work better.
So what does this all mean? Synthesizing everything we've uncovered today, menopausal insomnia is incredibly complex. It is a collision of a shrinking biological thermostat, fractured sleep architecture, and the psychological anxiety that builds when our bodies suddenly betray us.
It is complex, but it's manageable.
Exactly. By engineering your sleep environment, cutting false friends like alcohol, and utilizing powerful tools like CBTI, you can actually retrain your brain to sleep.
And remember, menopause isn't a disease, it's a transition. The goal of all these interventions is not to magically recreate the perfect, unbroken 8-hour sleep of a 25-year-old.
Right, that's unrealistic.
The goal is to achieve functional, predictable, and restorative rest that supports you through this new stage of life.
Functional and predictable. I love that. We spend so much time thinking of sleep as a passive off switch that just happens to us. But what if we started viewing sleep as an active skill? One that we had to actively practice, fiercely protect, and sometimes completely relearn as our bodies evolve. Definitely something to mull over tonight.